Welcome to this afternoon's panel, Integrating Shared Decision-Making into Home-Based Care. We have a great panel today from a variety of perspectives, so let me please introduce them. We have Rick Bassett, who's a clinical nurse specialist with St. Luke's Health System. We have Jeremy Bossi, who's a family nurse practitioner with St. Luke's Hospice. Kenneth McWilliams, who is with St. Luke's Home Health and Hospice. She is the operations manager. And finally, Lori Regan, who is a nurse and a licensed clinical social worker with the Hospice of North Idaho. And what we're going to do is have an opportunity for each of the panelists to talk a little bit from their distinct perspective. Then the panel will have some conversation, and then we will invite questions from the community. So please know that the chat is being monitored, and we look forward to hearing your perspectives. So we will first start with Kenneth.
Yes. Hi. So as far as a shared decision-making, so I'm representing the financial aspect of really looking at how we can incorporate the insurance piece into the shared decision-making model. And with that, I think a lot of times that piece is specifically left out and really can help us to make those shared decision-making opportunities. When we look at a patient in the hospital, oftentimes the care team thinks they know what that patient and family need or desire. Of course, we are the experts, right? And so, sometimes it's really taking that step back and looking at what insurance benefit do they have? Do they have Medicare? Do they have Medicaid? Do they have private insurance? And really seeing what their benefit affords them, and then helping the family to make an informed decision on their health care with including that information. Oftentimes it's a side note. Is that helpful?
Of course it's helpful.
Okay.
Thanks, Rick.
Thanks. And I think that some of the participants are wondering what a guy from critical care has to do with home-based care. And it actually has nothing to do with my professional job. I'm part of this panel because of a personal experience that I had. And my dad, during the pandemic, actually about in June of 2020, he entered a hospice care. And at that point in time, it was all kind of a new thing to me. Even though I was kind of familiar with hospice and home care, I had never been a family member of a patient that was receiving it in their home. And, it was a unique perspective. And I would say that when we talk about, making sure that the family is part of that decision-making, I learned that very early on that is a priority for those folks that are providing home care and hospice. I felt very involved in the decision-making. I felt like they did a great job involving my dad in the decision-making. And then, when my dad got to the point where his ability to maybe participate in that decision-making was limited, it was never to the point where he couldn't until the very end. But that's when some of the burden of that decision-making became mine, because I was the durable power of attorney for healthcare. But what I can tell you is that this topic that we're talking about today is so very important, because the reason why we all do what we do isn't because of making sure that we've got a good operational process in place, not making sure that we support insurance companies or do all of that stuff. It's about the patient, it's about the client, and it's about their families. And I think that hearing from our other panelists today is going to be very informative of how we can do that the best way possible.
Thanks, Rick. Jeremy.
Yeah. Thanks for having me, and appreciate your perspective, Rick. As somebody who works in hospice now, but has experience in palliative care, inpatient and consulting, family practice and critical care, all the way to back to working in nursing homes as CNA, I've sort of experienced the continuum, a broad view of healthcare. And shared decision-making is kind of a new sort of revolutionary buzzword, but I think what you observed matches with my experience, and that is it's pretty second nature to hospice. If the models sort of across the continuum are an old kind of outdated model of paternalistic, the doctor making decisions for patients and families, versus a sort of newer swing maybe of the pendulum to a consumerist model where patients come into a doctor's office or find themselves in a healthcare setting where they're sort of choosing from a menu of options. The middle ground there, I think, is what we're striking for, and that shared decision making. And because casting back, looking at where hospice came from, it was kind of a countercultural swing away from that paternalistic care where families and patients were really almost agitating for a shift in the kind of care they were getting and working hard to get their family members home. And so it kind of has that history to it. And so it just lends itself naturally to we're invited into patients' homes and into their world, and naturally they're the drivers of their care, and we really are sorting out and trying our best to match up the appropriate care for patients and families. I think that jives with what you saw, and I also just think it means that this isn't new to us. Understanding that higher quality care, finding the care that matches families and patients' needs more. Rick is right. We have one goal, and that's just to better serve patients and families, and with enough time and with empowerment that patients and families typically have more in the home. When you walk into a doctor's office, you're in different territory. Even I become deferential, with all of my knowledge to be a good boy and a good patient. And when you're in a family's home, they can, and given time, and especially, I'm jumping ahead maybe, but especially taking the perspectives of an interdisciplinary group, really asking questions from the perspective of a social worker who can really assess some of the struggle and suffering patients and families are dealing with, taking the perspective of a chaplain, for example. You really get a better 3D picture of what the patient and family's real needs are and preferences.
Thanks, Jeremy. I think you set Lori up really well. Lori, our nurse and social worker.
Deb, thank you. Jeremy and I found out when we were preparing for this is that we have a lot of similar thoughts and ideas. My experience over the years has been in home health, and then inpatient palliative care, then hospice, and now outpatient palliative care. So one of the most important things I think that Jeremy alluded to is meeting the patient and family where they're at. Again, it's not our agenda, it is where are they at. Sometimes it's a challenge if patient and family are not in the same spot. And so then you get to use those great skills to work and get everybody feeling like they're listened to. But that word empowerment is big too. And I think we empower people by telling them they can make decisions, their own decisions, but also by providing them education about their health care and about what's expected, what's the trajectory of their illness, what are their options for care. And one of the things that I have found is that sometimes if there's one provider, people understand, but other times they didn't necessarily understand what was said to them medically. Or if there's multiple providers, sometimes patients and families are being given conflicting information. And so our jobs as professionals, I think, is to try to help everything be understandable, to help them come to a middle ground, and reminding them again that they are the decision makers. But I think getting that communication between patient and family, but also patient, family, and providers. So those are my soapboxes.
Thanks, Lori. I think one of the things that you all have sort of touched on is the idea of shared decision-making requiring perhaps a greater level of communication, perhaps a greater level amount of time, and the necessity of being able to communicate over the continuum. And I'm wondering from your different perspectives, if you can sort of share, healthcare traditionally likes efficiency, and shared decision-making may not always be the most efficient model. And I say that in quotes. So any experiences or perspective that you can share on that?
Well, I actually, as a social worker and representing the financial aspects, I really think that we could become more efficient if we take into consideration the financial aspect from the start versus letting that come in at the tail end of decision making. So a lot of times the doctors or the team will come up with a plan, the patient perhaps and the family has bought into the plan. And I'm talking further upstream than hospice, and end of life care is over that continuum. But say if they're in the hospital and people say, oh, the patient needs to go to acute rehab. And then we've all kind of put acute rehab on the family, that's the level of care that patient needs. But when it comes down to it, they don't meet criteria for acute rehab. So we've built up this balloon that's now been popped, and we have to go back to that family and re-engage them. So I think it's important for us, if we're looking at efficiency, to look at it right up front of where's this patient at? What are they eligible for? And do they meet the criteria? And then helping to develop that plan. I think we inadvertently cause harm is maybe a strong word, but we set people up for some dissatisfaction because it's like, what, you were all saying we needed this and she's not even eligible. And so much rework is then done. So I think in this shared decision-making model, it is imperative that we start thinking about how do the finances or the payer, unfortunately, they are drivers more than we all want them to be, but face it, the pennies in their pocket. And so they're the ones that are really sometimes helping to drive that decision too.
And I think
Not that I agree with it.
from my perspective as a family member, so just a little bit more about my dad. He was a patient at the VA. He's a veteran, and he was getting immune therapy. And unfortunately, the VA, when the pandemic started, the VA basically said, we're no longer going to be able to offer that to him. And that was kind of a hard pill to swallow, but it was what it was. And right from the very get-go, okay, I knew that was kind of this is now an imminent terminal condition for my dad. And he had bladder cancer. And so, I was thinking, well, what's going to happen now? And I can tell you that there was from the very get-go. So thank you, social workers everywhere, because the social worker at the VA was already in touch with the social worker from St. Luke's Hospice. They were already having those conversations. I wasn't really involved in that at that point because they were trying to see what was possible from a home point of view. And we'd already discussed at the VA some of the goals of care, things like that with my dad. And so I agree with you that that's got to be right up front, because you don't want to set up an unrealistic expectation that this is what you're going to be able to access as far as care or treatment goes. I think the other piece too is I felt like, coming back to the continuity and the consistency, as far as from my perspective, and I don't know how much stuff happened behind the scenes, but I'm sure that there was a lot of communication that I didn't know about. But I felt like, okay, I just had that conversation with the nurse yesterday, with my dad and the nurse. And the next thing I know, the social worker's totally up to speed with what happened. I'm calling the provider to talk to them, or the providers involved. They know exactly what's happened. So I think it's really imperative on all of us who are providing those home-based services that we have to have a very good process of communication between all of our disciplines that are providing treatment for that patient in their home, because I think the consumer will probably pick up on that if it's choppy and if it's not well coordinated. And worse yet, I think that that'll affect the patient's care.
Yeah, it sounded like you had a good experience there with
Did.
integration of care even across the systems. And that is not necessarily an efficient process. Necessary though. I think integrating all of the information, I mean, these our patients clearly tend to be more complicated. We're dealing more with multiple comorbid chronic conditions in an aging population. There are more providers across the spectrum involved. These are complex patients with information overload issues on hand. And I think that slowing down to get there is what is a skill that palliative care in general, social workers specifically bringing to the table, just really taking the time to understand where the patients and their families are at, assessing their understanding of the medical situation, but also taking a lot of time to understand their specific characteristics, their values, their perspective, but also, we are privy in home-based care to a whole bunch of more information that you can, you sort of have the privilege of pretending doesn't exist when you're taking care of somebody in the acute care setting or in a doctor's office, but we don't have those blinders in home care when we walk right into the midst of it. So it really is wading in, taking the time, slowing down to really integrate and develop a plan that is tailored. And I don't think there's any way around it except to be very, to really take the time to understand the situation.
Yeah, the other comment I'd have on that is just that, maybe it's going to take 3 or 4 times of saying the same thing over again. I know that just because of my background, I picked up on things pretty quickly and maybe I asked the right questions, but I didn't want my dad to feel like, oh, well, my son understands it, so we can move on. I wanted my dad to understand every single piece along the way. And sometimes that meant that we had to explain things 2 or 3 times so that he understood exactly what this was going to be like and what his experiences were going to result in.
And I think you guys have alluded to this, but I'll say it directly. One of the first things I always ask is, what do you understand about your health? So that I can hear back. And often it's different than what we as professionals think has been communicated. So as you folks are saying, taking that time to have a conversation about it and making sure and explaining it as many times as is needed. And then the other thing is don't have to make a decision right away. There are those, one of you works in ICU, so there is that. But otherwise, we don't have to make a decision right away. Most of the time, especially in home-based care, we've got that time to work with people and to be respectful of the time that they need.
That's a great point. There are very few settings, even in the ED or the ICU, few scenarios where something has to happen right now, where shared decision making, unless somebody has to go to surgery ASAP and there really is no other option, there is always time to invite the questions, to assess understanding and have a discussion, even if it's narrowed down and tailored to an urgency, to have a discussion with patients and families about what makes most sense to them and remind them that they have the option of saying no. Empowering them again.
Lori, let me start with you. What are some ways that you have found to set patients and the people around them who are offering support? How do you set them up for success?
Great question. And from the time that I call to set up an appointment, we're having that conversation about were they aware a referral has been made? What were they told about it and what to expect? And then I talk to them about what services we provide and what they can expect on our end in a first visit and what that might look like over time. And then give them the opportunity to ask some questions about that.
What about from the rest of you?
Yeah, I'll chime in also as a social worker, but again, looking at it from the financial perspective that I'm representing today is really, say in the home-based setting, it's again, really understanding what your options of care are, how that relates from a financial perspective, but really getting down to the nitty-gritty of what these services look like, what the benefit looks like, and so that people can make informed decisions. When you look at home health, you look at hospice, we can talk about the goals of what both of those services provide, but then also providing what that benefit looks like through their insurance can also help them to make an informed decision that matches with their goals. And so again, just incorporating that. And sometimes it is getting down into the details of what does accessing medications look like for a patient with a chronic illness. And what's that going to look like for that patient and that family under the home health benefit? And what does that look like under the hospice benefit? And when you start talking in those specifics, the patient really and the family can really start to envision how their goals align with the different types of care that we're offering. But I think it's enabling them to understand the broader picture versus the home cares for this and hospices for this, and expecting them to fully understand. We may need to get a little more granular in our explanation.
Yeah, and that's where I was going to go. I think for me as the family member, success was in the details. One of the funny things, I guess, not funny, but funny to me was I totally had this expectation. My dad's on all these medications that, well, yeah, he's going to continue on his medications, but almost from the very get-go, they were helping me to understand that, well, he doesn't need these big horse pills anymore for this, or he doesn't need this. Their goal was to try and simplify my dad's experience, my dad's medication experience. And frankly, my burden too, as a family member, in trying to keep things straight. And so that was one thing. The other thing was all the different supplies that were coming into the home. And yeah, from an acute care point of view, I was familiar with some of the supplies, but I didn't know how to order them, who to talk to, but initially, but they told me these are, if you need more of this, or if you need this, or if this is an issue. And maybe, maybe I just had the ideal experience as a family member, and my dad had ideal patient experience. And maybe I knew to ask a lot of more questions than maybe the average consumer did, or family member. But I feel like for all of us that are providing that experience, the success is in the details. You've got to make sure that you get granular enough that they really do truly understand what you're talking about, and not only what the treatment is going to mean as far as, the outcome, but what does the treatment mean as far as what my involvement as a family member is going to be.
If I can just chime in on that, I think of a patient that I had once that had, I want to say he had liver failure, and he had urinary retention. And I was out there, I was working both home health and hospice at the time, but this gentleman needed a catheter placed like now or yesterday, right? He had so much urinary retention. And the family, he was on home health, but just sitting down and talking to them of what we would be able to achieve right here and right now under home health meant the nurse went back to the office, called the physician, got the order, would come back out. If the patient's on hospice services, the pre-approved standing orders may already afford for that. So the nurse has that available at her hands, goes out to the car and provides comfort and relief right at that time. So again, being able to explain that to the family in real time of need was, again, that was kind of a granular example of what I'm getting at of what this can look like for a patient on this service versus this service. Not that one's right or wrong, it's just the regulatory guidelines that maybe tie the risks for the home health providers to be able to implement that quickly to provide some comfort there. But maybe, that more aggressive treatment and was home health, or did we get them to the hospital right then?
Yeah, you're talking somewhat about providing the right care at the right time. to the
Exactly.
right patient. Yeah, I guess my answer to the question about how do we best set up these patients for success is to define success. And that's very
Wow.
subjective.
Well stated.
And I think the approach requires humility. I think it really requires going in there, as Lori, I think, mentioned, without a big agenda, except to better the care for the patient and to ease their suffering where we can, improve their care, but to really find out what success means to them so that you can match up the right kind of care at the right time. And that, again, I think that takes time, and it takes humility to sit with and listen to the story, the preferences, the values of the patients you're taking care of, to help then make a recommendation that they have the option of saying no to or saying yes to, but to make the best recommendation that would to set them up for success, just to match the patient's needs best.
Lori, you look like you might be ready to come in.
I thought that was perfect.
One of the things that I've heard is the notion of being in someone's home adds a different element to the care. And I'm wondering if Rick, as a provider, if you might be able to speak to how it was to be a family member in that space. And for the rest of you, if you've had your own personal experiences being on the other side of the bed, so to speak, or how it is that you as providers of care think about being in that space and creating opportunity to share decision-making and to listen and be attentive to what patients and families are telling you.
Well, I'll tell you, I'm thinking about things that my dad said to me. Sometimes before the nurse or the social worker were going to be there or after. But it takes a special person. It takes a special set of skills to do this. And almost from the very get-go, I might get a little emotional. They made a true connection with my dad. And that meant a lot to him. And he could trust them. So when they were imparting of this wisdom and these options, they knew that he knew that he could trust that they were giving him the best options. And like I said, it didn't matter after the social worker left or the nurse left. Wow, that was so good to see them. And or before they came, I'm sure looking forward to seeing them. I want to ask them some questions. So I think that preparation on behalf of you all before you enter that home is important. And to know that for that period of time that you're with them, you kind of are part of the family. And it's different than the relationship that I have when I walk into a patient's room in the ICU. It's a unique place for a healthcare worker in somebody's home.
Yeah, I just feel like it's a privilege to walk to go into somebody's home. I recognize it as a privilege, as an invitee into their world. You cede a lot of control. I guess that's one way of kind of looking at it as a healthcare provider, in favor of the family, and the power nexus really becomes more in favor of the family and the patient and their own choices and decision making. And I just think you can't help but recognize that when you're on their turf, when all of the healthcare, the fixtures of healthcare and the equipment and technology and aren't at your disposal right then and there. It really is more of a conversation of equals. There's no denying that it shifts the power dynamic, and that's a good thing when families and patients can feel empowered on that level.
Yeah, I think the other thing I would add is, as a family member and advocating for my dad, I had long conversations with him about, whether or not he wanted to go back into the hospital and what that would mean. And I knew what it would mean for me as a family member if he went back into the hospital during the pandemic. It meant that I would have little to no contact with him personally. And so this home-based care option is not just something that was so special during the pandemic, but I realized that this is where healthcare is going. Healthcare is going to the point of we're trying to keep people in their home because of that special experience that you have in the home. You still get the care that you need, but you get it in a place that you're comfortable and you have all these things around you that are familiar. And so I just wanted to add that.
Yeah, I too want to piggyback on that, and what Jeremy said as well is, again, from a social work, but hospice team, home health team, I think it really affords us the opportunity in the home setting to provide that patient-centered care that we all look so forward to participating in, because we are crossing that sacred ground into somebody's space, and we see the life around them. We see the pictures on the wall. We see the 67 Chevy in the front yard. And so you're able to connect with that person as a person, where in the hospital, you're absolutely right. It's all the mechanical stuff, all the equipment, and everybody has the same gown on. And so I think sometimes, unfortunately, we don't get to dig in or visualize it and experience it or smell the apple pie like we do when we walk into the home. And so I think it does afford us that patient-centered care.
So, yeah, all good points. And I think there's an additional side to this. I think in the hospital, we get from patients, I can do XXX, or here's what I have at home and here's what's set up. And we get into their homes and sometimes we're surprised that, actually they don't have all of the services they need. Their environment maybe is not as supportive as it could be, not only physically, but with who else is coming into the home. And I think we've all been into those homes where we're surprised and we're quite concerned about the patients. I agree, relationship is huge. And I think we've all been shown wonderful pictures of people, and they'll show us here's what I looked like a year ago, and here's what I look like now. And we get to see that difference in the person, but also connecting with family, which brings me to a really important point before we ever get into the home. Who needs to be present for this conversation? Because my experience is, we can call and say to a patient, we're coming out, and they'll say, okay. But if they have people in their lives that help them with their decision making and that are important to them, and they're not present, it's probably not going to be very helpful. And we're going to be, taking an extra step that we don't need to, and we want everybody involved that can be. I have had many a time, as I'm sure you folks have, where we put somebody who lives out of town on speakerphone, or somebody who's working, can we get them on their lunch hour? What's the best time to schedule so that everybody that needs to be present can be?
You as panelists represent care that is provided in rural settings as well as more urban areas. And I'm curious whether this idea of shared decision-making translates differently. And if so, how?
Well, it certainly, what's available to a patient in a different setting, it certainly drives the care. We're talking about patients who may not have the option of skilled nursing facilities and assisted living facility, paid caregiver options, rehab, skilled therapies of all kinds. And that's just an access to care issue in rural settings. And so it certainly does shift the menu of options we have to present to patients and how they look at their care. So it's a challenge. I mean, it tends to be more of a challenge for our rural patients, and including the response times for us to attend to them. Our patients are choosing to live in a rural setting, the rural lifestyle. They're often accepting of those kinds of limitations, but the reality is that as your needs shift and as the reality on the ground changes, and as these kinds of issues move from the hypothetical to the real right now, I've certainly met the rugged individualist who wants to live in their cabin or on their ranch until the very end, and will accept some of the risks of that. But when the rubber hits the road and they have a crisis, and it's not the end, it just presents a real struggle, then there's challenges to solve those problems and offer solutions. I mean, that's one perspective, I would say.
And I would say certainly rurally, there are less resources available. On the flip side of that, sometimes neighbors and family are offering more help perhaps than we are in the city. And they just expect that that's part of their role. So that's a positive.
I agree. And really it again falls to eliciting patients' values and their own perspective. You may find they are readily accepting of the risks, and they're not surprised at all that they wouldn't be able to get a nurse to the home, for example, that it would take hours or wouldn't even be possible depending on the weather in our Idaho winters. And they're simply accepting of that. And we support them the best we can, given that situation, whereas you would, you know, other people, even somebody else who lives rural you might have to build a different bridge to care for them. And it may mean a move into a different setting, into a skilled nursing facility. So it's all back to, here are your options. Here are some of the attendant risks of this option versus that. And how can we best fit together a care plan that matches what you would want for yourself?
You know, that was one of the things that my dad said. I don't want to go in he called it a nursing home, but it could have been anything, but he didn't want to go anywhere but his home. And so I think that, you know, he didn't live in a rural area. He lived right here in Boise, but he was basically willing to accept whatever limitations that meant. And I don't think it really meant too many limitations. He still got the best treatment that hospice would afford. And, you know, because it was Boise, he probably had, you know, if he needed somebody to come by, it was not too difficult. But it's important to understand exactly, you know, when you're, like you said, start with the financial piece, understand what the options are, but then aligning that. I think Lori said this, understanding what your patient, what your client's looking for, because then you don't put things on the table that are nonsensical to the client. They don't really want that, or it's not really important to them. And then you don't have to clutter the conversation with that nonsensical or that unnecessary stuff. It's just what's going to be really beneficial to them and make their experience the best it can be.
Yeah, it turns out that patients aren't necessarily as risk averse as we are in healthcare. In our
Right.
professional roles, we by necessity, we have to be risk averse. We have to think about all of the problems that could arise, and we should do that.
Right.
And when you present that to patients and families, it's often that you find that, you know, they'll appreciate that. They understand the risk of a fall or the risk of recurrent chest pain, you know, or the risk of a complication, and accept that. It wouldn't be uncommon at all in a person who's lived in a rural setting for their whole life to just
Okay.
say, yeah, I can handle that.
Mhm.
That's the beauty of being able to defer to a patient in making the ultimate decision, given the best information you can give them.
One of the things that you have highlighted is the idea of providing communication that makes sense and providing a set of options or decisions that also make sense. And I wonder if you and your professional hats, and Rick, again, from both sides of the aisle, have any tricks that you can share or advice that you might share in terms of what has worked for you, or maybe even what hasn't worked?
I'm going to listen to all these guys after I say one phrase. And this phrase is, and I've used it professionally as well as personally, help me understand. That will elicit so much information. If you say that and then listen, then you could probably ever get saying, well, here's your options, and, you know, just help me understand.
Yeah, it's a way of testing their understanding and assessing their level of understanding of sometimes complex information. I think that's brilliant. That's right on. And it's what it's what we need to do, is test their understanding repeatedly. We can baffle people with jargon and medical ease, but it's really not that hard to ask what they understand in their own words. And it doesn't have to be made more complex than it needs to be.
Well,
I
and
don't
that
think
help-
that's a one-time ask, right?
Right.
We ask that
Absolutely not.
initially. Yeah, what are you understanding? And then we ask it throughout the process. And sometimes there's a teach back, right? So very helpful.
Yeah, we can't put somebody through medical school in, in the time we have to relate the medical situation and the options. And we don't need to. I think Lori's exactly right. You ask and ask again and offer new information or more information and test understanding and keep your ears open. And also I would bring it back to the interdisciplinary team and the value of different perspectives on a situation, the value of bringing in social work and nursing and chaplain disciplines to get a read on just what information is important for people and what isn't. So, we are challenged oftentimes to offer a prognosis, for example, and that can include a lot of medical, technical data with a lot of uncertainty. And we try to integrate that as best we can and offer a recommendation. It turns out the things that are more important to families and patients, though, are not so much time or exactly what the statistics are for the outcome here, but it's what's functionally going to be happening next. What's my life likely to look like at home in the next months or year? And those are perfectly within the purview of our social work and nursing team members to help guide families through and prognosticate about what experience shows patients' challenges are as time passes, and help them navigate that information.
I just wanted to comment on what Lori said. We do have to go back and confirm understanding and things like that. But the other thing too is how many people out there have consulted Dr. Google? And Dr. Google is just such an incredible resource, but unfortunately, Dr. Google isn't always accurate, and there's a lot of misinformation out there. And so I think it is our responsibility to make sure that what do they understand, and then to help clarify and to help correct, if needed, their understanding of certain things, because they may have had a friend that got hospice or got palliative care at home or whatever, and everything they heard was third party, and it just was not reflective of what that experience is going to be like for their own family members. So kind of addressing the misinformation that's out there is also a big deal.
Yeah, that's really where my mind was going with the question too, is really seeking to understand, whether it's tell me more, really, say, like you explained that your father really wanted to stay at home, but we have a lot of families that really are patients that say absolutely not to a skilled nursing home, or absolutely not to hospice. Hospice means I'm going to die in 48 hours or whatever that is, whatever their understanding or belief is, or horrible experience they had within their family system. And so tell me more so that I can really understand and respect your autonomy and your self-determination. But if we just don't seek to understand where that resistance may be coming from, then we might still be pushing that nonsensical subject on someone, not understanding their frame of reference. So I think it's really looking at that. Also with, say, if I'm offering private hire in-home care, the amount, as you all know, for 24-hour care in the home and what that looks like can be so expensive these days. And but really again, sometimes do they really need 24-hour care, or do they need 24-hour care? This was what I did from the hospital a lot, is let's get 24-hour care for the first 3 to 4 days. Then let's pull all those decision makers back together and see what is really needed. So taking the big, breaking it down into the small. So hopefully that then it's like, no, they sleep every single night for 10 hours, and they don't really need someone at that hour of the night because they're sawing logs and they're not getting up or whatnot, at least for the here and now. So we can break it down to 4 hours in the morning and 2 hours at night or whatever. But breaking it down can be helpful.
Other thing I just wanted to throw in real quickly is back to when we talk about that trajectory of illness. Here's where you are now, and here's what we expect to happen over time and looking. So we do have that conversation with people, but also to give it to them in writing, and they can refer back to it. And some of what I've done is, and here's the decisions you're going to be asked to make at each stop along the way. So that's been very helpful. Another thing that we've been doing in the homes are a plan of care. So I came and visited you today. Here's what we did, and here's what you can expect from us next. We're setting up this appointment for you on this day with this member of our team, or we will call you on this date, but also you can call us. So just leaving written information has been very helpful.
Before the panel has a chance to sort of sum up, I want to check and see if there are any questions in the chat to tend to. I'm hearing there aren't any. So I think that all of us would agree that, Rick, the kind of experience you have described with your father is something that we would want for everyone.
Absolutely.
And I'm wondering, from that experience and from, again, your perspectives as providers, what is one step that you think the medical community and providers could do in order to improve the odds of shared decision-making happening and having the good kind of results that your family had?
Well, I would jump in and say to model and replicate the success that hospice has achieved over time with the interdisciplinary care team. I would say transdisciplinary, and it's just a matter of semantics, but that model is very successful in patients, and we know it works well for patients of all stripes, and hospice is available technically just to those patients in the last 6 months of their lives. But there's reason to consider the model in some form to apply to a broader range of patients. I think if I had my magic wand, it would be something along those lines, either expanding hospice eligibility criteria or some form of a similar model expanding to support patients of all kinds in their home, patients not just with terminal illnesses, but multiple chronic comorbid diseases and challenges.
I think a couple of words that come to mind for me are communication and respect. Without respect, then you're not going to have trust. And without trust, then it's not really going to be a great experience for anybody. So the respect piece has to come first. When you're in their home, mentally as well as physically, meet them where they're at. I think Lori mentioned that sometimes you'll find situations that somehow we need to resolve some of these concerns that we're dealing with. And sometimes that's going to take some very delicate discussions to do that. The communication piece, as we all know, is not something that every healthcare professional has strong skills in. And I feel like that may be why home care and hospice folks excel in what they do, because they do have strong communication skills. And a lot of times people are cutting their teeth, so to speak, in the acute care setting, and they're learning all of that. So coming back to your question, how can we do this? I think that it almost harkens back to what happens in the academic experience, and how can we really drill in to the, not into the people, but into the academic experience, that communication is paramount to every experience you're going to have with your patients or clients. And if you don't make that happen, then it's not going to be the experience that it could have been.
Well stated.
Yeah, the field of palliative care is going great guns to improve communication, and there's all kinds of new novel approaches, not just to offer education to providers of all stripes, seasoned providers with lots of years under their belts, and a new generation of providers who are appreciating just what you said, that the skills are specialized. The communication skills can be learned, and there are wonderful initiatives out there like Vital Talks in
Mhm.
oncology, offering just a refreshing and important new development in that education piece.
And I would say team, as was mentioned earlier, use your team. Big difference to get to have the people with their specialties go in. And I also want to just say thank you to all you people going out into the homes. I know you're doing good work and you're very needed.
I don't really have anything else. These fine folks summed it up well.
I would echo that as well. What a wonderful panel, engaging conversation and lots of good thoughts to take away from this. So on behalf of everyone listening, thank you so much for being willing to share and share both the professional and the personal, and are grateful for your commitment to providing the very best of care in all the settings that you work. And thank you for your participation this afternoon.
Thank you.
Thank you. Pleasure.